Ryan Stanton here with ASEP Frontline. Today we have a special podcast exploring some of the opportunities to protect patients in the emergency department through vaccines. And of course, right now, vaccines are all the rage, all the talk, because it has become something of kind of the focus of the COVID-19 pandemic with the vaccines that are available out there right now. But it's a great opportunity to discuss the fact that this may not be where we stop in the emergency department. The emergency department's always been a place where we update tetanus status when somebody comes in with an injury. You know, hospitals will do some of their vaccines, the flu and pneumonia-based injections in the hospital, but it's never been really a place where we think the emergency department is the source for vaccinations. And it's time for a conversation on our role as the emergency department and potentially expanding that role as an access point to make sure that our population is adequately vaccinated, especially with certain things and common hitting things that are out there, and being one of the main contact points for a lot of a more vulnerable population or population that doesn't have access to healthcare otherwise. So I've got a couple of physicians. We're doing an international-based podcast today. We're dealing with, they're not really too far from each other, honestly. We're talking about Maryland and Toronto. It's a lot closer than I am down here in Bristol, Tennessee right now. So we'll start off, just let introductions and history and kind of how you got into this. We'll start with you, Dr. Hirshon.
So John Mark Hirshon, I'm a professor in emergency medicine and also in epidemiology and public health at University of Maryland in Baltimore. I trained in emergency medicine 30 years ago and then did a second residency in preventive medicine. As we were talking about earlier, preventive medicine and vaccinations are something that I've been interested in for a long time. And my background is that when I was interviewing for preventive medicine residency, they asked me, "Why do you want to do this?" And I said, after you've treated enough folks falling off their bikes with head injuries, you start saying, well, gee, why don't we have better public health? Why do we have better ways of treating people to prevent the disease? So we need the laws. So looking at public health and looking at the ways that we can utilize the emergency department as an access point for improving access to high quality care, I think is very important. And that's something that I've been doing for a long time.
Great. Well, that's great, John. Thank you. I'm Dion Neame. I am assistant clinical professor at McMaster University here north of the border in the Toronto area. And I'm quite a similar history to John's, actually. We were talking about that before the podcast. And I also am in the emergency room regularly. I'm actually working with Sanofi right now as well on the other side of the fence, which is an interesting place to be. And it's where I utilize my primary prevention of disease expertise, which is vaccines, essentially. And so it's very interesting to be in a conversation like this where we're talking about kind of polar opposite sides of the disease spectrum, from prevention, proactive, to very acute care medicine. So I think we'll have some interesting conversation today.
We're talking here. We've got two great physician minds, and I led off talking about COVID-19, and of course the entire world has been almost laser focused on COVID-19 for the last 13 months, and that has actually, unfortunately, led to some gaps in some of the traditional things that we do, some of the screening and evaluation and prevention and all of those things that you gentlemen had just mentioned. Kind of delve into not only the emergency department transitioning from that reactive to proactive, but also some of those challenges we faced with this focus we've had on COVID-19. Dr. Neame, I'll start with you.
Well, COVID-19, a little bit of an unexpected surprise there. And it's an infectious disease. And now we've been dealing with infectious disease, and John can talk all night and all day about this as well as I can, but we've been dealing with this for over 100 years. And vaccines, big history in Toronto, big history in Swiftwater, Pennsylvania, and a lot of different places about how you can affect the immune system in a positive way so that you can use and utilize your immune system to protect against something new like a COVID-19. And so that's why everyone's talking about vaccines, because that's exactly what we're doing. We're just taking a spike protein off the SARS-CoV-2, and we're developing vaccines, multiple different vaccines on that. But this, I say, this is nothing new. We've been doing this, like say, for 100 years. Tetanus is a classic that we could talk about. But when you're talking about breaking the chain of infection of any infection, in this case SARS-CoV-2 You basically have 6 elements in which you can break the chain of infection. And vaccines is a very effective way of doing that.
And Dr. Hirshon, how has this focus on COVID-19 maybe distracted us from some of the other preventive health and monitoring statuses that we typically would do, not only in the system, but in the emergency department as well?
Well, I mean, I think when you look at things overall, the screening for cancer outside of the ED per se, the screening for cancer is way down, and that's starting to come back. And so there's the potential that that the impact of COVID is beyond simply the acute infectious component, but really, not finding the individuals who may be at risk. Now, in the emergency department, there's been a lot of challenges with the isolation and the separation that we've needed to do. And so, there are patients that I've taken care of whose family members can come and help me, can give me information. So I think there's a lot of different ways that the infectious disease process, the COVID, has kind of limited our opportunities and have diminished some of what we can used to normally deliver because of it.
And with this, a lot of times when we start talking about the idea of vaccinations, in the emergency department, and some of these preventive and monitoring measures, so many emergency physicians, so many departments say that's not my bag, baby. This is not my lane. I need to, vaccines are primary care. Vaccines are public health. We need to be the assessment, stabilization, disposition of acute medical or trauma experiences. But why, as emergency medicine, do we need to reset that narrative and say, we need to rethink that approach, that we may be the right location with regard to access to vaccinations and those types of questions with our patients?
No, I think it's a great question. And I think it's one I've had conversations about for 30 years. And the first thing I would say is that, look, we've been doing tetanus for as long as I can remember. And that's a preventive measure. It's easy enough to do it. And sometimes we've given influenza vaccinations, especially, or pneumonia vaccines for certain populations who are elderly. I think one of the biggest challenges we face is that we haven't had the technology to know what people got and what they haven't. So the EMRs should really improve our ability to administer vaccines. And then another component of this from a population and individual perspective is that a lot of people out there don't seek care or only seek care in the emergency department. So with the opportunity to prevent disease, because they've come in, they've got an injury, but they need the COVID vaccine, or they've come in injury, they haven't had influenza vaccine. Those are the type of things I think we can really take advantage of. So with the improving technology that we have, we can improve communication, improve service delivery in those areas, and potentially decrease risk for our patients for acquiring vaccine preventable diseases.
I think a lot of us, you mentioned tetanus, and we have Dr. Poole with us as well. He's kind of in the background here with us, but he mentioned even before working with pertussis, we had a lot of outbreaks here in the United States. Especially near my community, we had several pertussis outbreaks that took place, and we was like, listen, we're already doing tetanus, but there's already a vaccine that exists that involves acellular pertussis as well. Why not, when we're protecting against potential tetanus, also protect against this disease that is making a comeback and actually is a significant disruptor, significant risk associated with certain populations, especially pulmonary disease patients, asthma, COPD, and the like. And there's a reason it's called the 100-day cough. It's not because it makes you feel better for 100 days. And so the ability to then take one step to benefit another, and I think that was an easier pill to swallow, figuratively speaking, for the healthcare industry, because it's already bundled with something that we needed to do anyway. And so that transition and that mindset to say, you know what, we are the site for the episodes of acute care, but also we have a significant and potential huge impact on public health and prevention by just doing some simple things and having that access there, and even putting in that infrastructure to do that. Dr. Neame, as we kind of jumped a little bit, but give us a little background. And you mentioned a little bit when you answered before, but some of the background on vaccinology and the immune system. And you mentioned that as part of those it's one of those 6 steps in preventing a virus like COVID-19. Talk about that a little bit more and the evidence of impact that vaccines have on case rates and hospitalizations of other infections, not just COVID-19.
Yeah, I think, okay, maybe I'll just back it up a little bit. I thought you were a really great example using pertussis. And let's maybe just talk about respiratory infectious diseases right now. I mean, we all know that respiratory infectious diseases are going to cause problems. As a pediatrician, I see it regularly, whether it be respiratory syncytial virus, whether it be influenza virus. I mean, these can directly cause issues with the respiratory system, and that's something that we need to deal with in the emergency room. And that's something, of course, when we talk about influenza that and pertussis, we can protect by vaccine-preventable diseases. But there's much more going on than that. And this is something that we've really understood using real world evidence. And that is that infectious diseases don't just sit alone on an island by themselves. They, in fact, and well, let's just talk about non-infectious diseases for a second. They don't sit on an island all by themselves. In fact, when you're talking about an infectious disease, which then goes on and infects you, stimulates your immune system, there actually can be a lot of indirect effects that can occur that can affect these non-communicable diseases or chronic diseases. We've understood now that particularly in people that are 65 years of age and older, if you get an influenza infection, yes, you will get sick with influenza, but it can stimulate your immune system, particularly your innate immune system, to affect influenza in a good way, so we can get rid of that. But also, because it's an innate immune system, it's a generalized immune system, it can work its way around the body and start chipping away at other things. The theory is that if you get an influenza infection, you stimulate your innate immune system. Your innate immune system goes around the body, says, oh, look, there's an atherosclerotic plaque. What's it doing there? And it chews away at the atherosclerotic plaque. It creates a bleed within the vessel. Then, of course, your coagulation pathway goes on, creates a clot. That's a good news story. The only problem is that sometimes those clots actually are blocking the blood that's going distal to the end organ. If it happens to be the heart, you have a heart attack. If it happens to be in the brain, you have a stroke. If it happens to be in the glomerular or the renal, of your kidneys, then next thing you know, you have renal disease. So what we're saying now is it's not really just about the infectious disease and causing direct problems. It's the infectious disease causing direct problems and potentially stimulating the immune system and then getting indirect problems. But here's the whole thing. It's all stopped by vaccines, vaccine preventable diseases. So now we can open up that spectrum of disease that can be prevented by these types of respiratory infectious diseases. COVID, oh goodness, has that ever given us some ammunition on that front? We see so much happening with COVID from a perspective of some people are asymptomatic, some people have mild disease, some people end up in the emergency room, some people end up in the intensive care unit, but it all stimulates from that SARS-CoV-2 virus causing disease of COVID-19. So if we get a vaccine, then we can break that. Now, to your chain of infection, you can break it any way you want. I mean, when you've got the chain of infection, there's 6 different elements. There's the infectious disease, which of course starts it all. And now what are we seeing? Variants. Okay, so that can be complicated. We have a reservoir, people, bats. So the virus can spread and stay within the community. It has to break out of the reservoir and has to transmit, whether it be direct or indirect droplet aerosol, through vectors or what it might be, and then has to get into the susceptible population. Now, the susceptible population here at COVID, my goodness, if you happen to be in a nursing home and you get COVID, it's not a good news story. I mean, you really have some great difficulty. So when we have vaccines that can prevent it, and we have many now, of course, the mRNA vaccines, the viral vector vaccines, some of the protein-based vaccines are coming quickly. You can actually then focus in on that group. Now, let's say, for example, someone comes into the emergency room and they happen to be from the nursing home, or they happen to be someone living at home independently, but they're 85 years of age, and they have chronic disease. You know that they're going to be susceptible to the disease. What would be a better place, what a captive audience in that 85-year-old person to say, you should get a COVID-19 vaccine. And you know what? I have to have one in my fridge here. And I think that's where the emergency room, the interface, has great advantages. I see John smiling there.
There's a lot of opportunities that we can look at, and what we're trying to do in this whole conversation is to decrease the risk for our patients. Now, there's some patients we clearly know have more risk than others. The elderly, those perhaps with obese for this disease, respiratory problems for other diseases. And if we can stop that train from leaving the station, it's a huge difference. Okay. And so, if we can get people to to get their vaccines, and we have the ability to give that vaccine, then that's really an opportunity that we in the emergency department can take advantage of. So I totally agree with what's being said. The key here is to get us as physicians and our departments to change behavior to help prevent disease, as well as the acute management and treatment once that a disease occurs.
Great segue, because that's actually my next question is into the looking glass, into the future of emergency department standard of care. We know that things such as tetanus and now pertussis are part of the standard of care treatment of people when they come into the emergency department with an injury. You fall, you get a cut, whatever. That's one of the main questions. When I have a student, did you ask, what's their tetanus status? That's one of the main things you have to ask. If you go to ABEM General and you don't ask that question, you fail that section. So, for residents coming out, just remember that. Always ask about the tetanus, whether it's virtual or in person, whichever it's going to be this year. But let's look at the future standard of care, the opportunities to the mindset for proactive medicine in the emergency department, and some of the overview of the vaccine preventable diseases that aren't typically on the radar of the emergency physician. And I'll get both of your opinions on that, and then some of the barriers that may be in there as well. Dr. Neame.
Well, it's when you're in the emergency room, emergencies are going on. Emergency department emergencies are going on. No surprise. And there's not a lot of time for taking long histories. So, for example, if someone's in front of you and they're having a myocardial infarction, you're just getting it done, right? You're trying to save the person's life. Not a lot of past history. Yeah, so what was going on last week? Were you having an upper respiratory tract infection? Do you have an influenza-like symptoms? So it's sort of difficult to convince the emergency department physician that these infectious diseases cause problems. And so when you're having these discussions, maybe at rounds or whatnot, it's bringing in that real world evidence. There's a great study here at the University of Toronto, which is talking about myocardial infarctions in people 65 years of age and older. And it basically looks at it from a perspective of 2 years. And the important part is that for the day that you have influenza, 7 days after, what they find is that you're 7 times more likely to have myocardial infarction than you are a year after that week and a year before that week. And we don't have it, the pathophysiology all locked down, but those are the hard numbers. The CDC, Medicare, Medicaid, they've looked at, gone through and they've done real world studies on some of that Medicaid data that they have for 65 years of age, and they're noticing the same basic things with influenza. And that influenza is an example that I'm using. And so if you can convince the emergency physician that, this is a real important part of our standard of care, that yes, we should obviously, save people when they're having myocardial infarctions, but we have to understand that that's a risk factor now when you're talking about influenza, to have another one, or to go to congestive heart failure or something like that. And so we should think patient, myocardial infarction, patient, congestive heart disease, and a multitude of others, whether it be respiratory, chronic pulmonary disease, whatever it might be. That's a person that needs to have an influenza vaccine. So when we see them, once again, they're in the emergency room, they're listening. You're at risk for having a bad outcome from an infectious disease. I've got a couple of vaccines for you. I've got one vaccine for you. And I think that that's how we have to sort of change that mindset to get the physician out of the place of just acute medicine, very much like John and I. We do that, but we also have our crime prevention or public health arm. And that's what we have to try to convince them to do. Think of it. Think about it. That's the patient in front of you. That's the patient that's going to run into trouble. We can prevent this. So let's do that. Let's vaccinate them.
Dr. Hirshon.
Well, we talk about tetanus as an obvious example of what we do as standard of care currently. I can give you another disease process when someone comes in that we ask whether or not we should vaccinate for. And when that is if a pregnant woman comes in who's Rh negative, okay? And that's part of what we look at from a risk. It would be considered, ABEM, I would not pass ABEM General if I didn't ask that question as well. And so I think we have to understand that the risk factors, there are multiple risk factors for various diseases, and we're getting more and more knowledge about how those interact, and recognizing that the disease course is not always as predictable as one would like. You get COVID, maybe you'll be healthy, maybe you won't, and there are risk factors that we can identify which put you at greater risk. So if someone comes in with influenza, and they're being admitted to the hospital, then we're going to want to treat them and try to make them better. If they're coming in and they're not that sick, can we do something to prevent it? Another example, let's say that we have a patient who comes in with sickle cell disease or who doesn't have a spleen. We should be considering, has this person gotten a pneumovax? So we know that encapsulated organisms in this individual puts them at greater risk. And so I think we need to change that mindset to understand that we as physicians have a responsibility to take care of our patients, even in the episodic care, to make sure that we're doing the best we can for them and by them. In that instance, considering some of the preventive measures. I think that we've had an argument against it because it's been a difficult lift. But as things become online and EMRs become more interoperable, then we should be able to pull that information with one click or 2 clicks away, and then we can make a rational decision about, yes, you got an influenza vaccination last year. What about this year? Let's talk about that. And so I think that as we move forward, recognizing we're already doing this in the different sectors, how do we make this a more standard of care across the particularly infectious disease domain?
That actually reminds me that if you want to hear Dr. Hirshon, he was the last interview we did with him here on this podcast, on the Frontline podcast, was on sickle cell disease. And so that's one worth looking back in the archives and checking it out. I think that would have been in 2019, early 2020, because I think we recorded it ASAP 2019. And you actually led us into that next discussion. You mentioned the improvements associated with EMRs and data collection and being able to track where somebody may be on their vaccine needs spectrum. And so that gets us to the opportunities. So I want to talk about opportunities and barriers because physicians and systems are looking at it now and saying, okay, I understand where we're going with this. What's going to make it work? And then what are the things going to stand in my way when I start to put one of these programs in and looking at what may be applicable within our system, starting with baby steps and then kind of working to more opportunities. So let's get from both of you, let's start with opportunities. What are some of the opportunities and reasons this is a good time now to make this happen, Dr. Neame?
Well, I mean, everyone's talking about COVID. Everyone's talking about COVID vaccines. It's just shocking how much people know about vaccines now compared to about 2 years ago, a year ago, really. And I think that's changed the way people perceive them. I think that the vaccine hesitancy has changed somewhat. I think people are more amenable to getting vaccines. And so that provides a tremendous opportunity for us. I do think, as well, as I mentioned a couple of times, though, when you're a patient in the emergency room, you're a captive audience. You are listening to your physician. I mean, you're sick. Primary prevention of disease is fairly challenging because people aren't sick, so they're not sick, so why would they do anything? You are ill, and you're listening to a physician who's doing a lot for you right now. So there's a great opportunity as well, too. I'll just leave it at those two big ones, and I'll pass it to John.
Well, again, I think the opportunity is that we know that people unfortunately wait a long time in the emergency department. And I think we can take better advantage of that time. Give them information to look at, to consider. If you were to come into a young patient in the emergency department today and say, would you like a COVID vaccine? Most people are going to say yes. We should be considering some of these other vaccines as well. So I think there's a lot of opportunity. And one of the nice things right now, particularly for the COVID vaccine, is the fact that there's funding for it. And unfortunately, money comes into the equation as we take care of patients. And I think part of what we have to look at is that if we are going to deliver these services, can we make sure that we get reimbursed for them? Because that helps to support the activities that we want to do.
And there's always that whole idea of striking when the iron's hot. And you both mentioned COVID-19 and the vaccine being on the front of everybody's mind, seeing the impact of worldwide pandemic, vaccine kind of shifting us out of that current state of affairs and using that as a stepping stone to move forward. Dr. Hirshon, you mentioned some of the EMR advancements. I mean, most EMRs now are having significant connection and workability with primary care offices, being able to keep that data with pharmacies and wherever these sources may be, being able to pull that in. So we're getting the technology there. Dr. Neame, you mentioned having the captive audience with them there in the emergency department. Can we manage that acute phase of care, but also that opportunity that we can prevent care later? So a minute or two of investment now may save an entire visit later, an entire episode of care or hospitalization or whatever it may be. And I think that's one of the big leaps for emergency medicine is we've always been a reactive profession. We've always reacted to illness and injury and not really positioned ourselves in the preventive realm to say, this is how we prevent. Now we educate. And Dr. Hirshon, you mentioned the helmet on kids with bicycle accidents. We do a lot of education, but honestly, though, our whole job is designed around that reception of an acute care phase, and not necessarily in thinking forward on how do we prevent that moving forward, or what can we prevent by doing this here. Take a couple of minutes now, and we've done it. We've dabbled in it a little bit. There's been some studies about alcoholism where if we take a little 2-minute intervention, we significantly decrease binge activities and high-risk activities and risk of drunk driving accidents and death associated with it. So a little intervention, and we do some of that. But vaccines, one of the great accomplishments of modern science is the ways that we can actually prevent disease processes from happening in human beings. But there's going to be barriers. There's going to be things that stand in our way. So let's start off by talking about some of those things that may get in the way of putting these into practice within the emergency department. Dr. Hirshon.
Well, I think first to start off with is to change the attitude and cultures of those of us. I remember having many conversations about vaccines. That's not part of the ER realm. And so I think we need to understand that it is part of what we are and what we do. We're doctors. We take care of patients. We want to prevent disease as well as treat disease. It gives us a great opportunity to make a difference in people's lives. And so for us, I think the biggest barrier to start with is to change culture, because culture eats strategy for breakfast, lunch, and dinner. So you can have the best strategy, but you got to change the culture. Second of all, there are a lot of just barriers. We have to get paid for it, as I said, simply because that's the nature of it's a job and that's what we do. We have to make sure there's enough ease of data acquisition. So we need to make sure that there is interoperability between the EMRs, and there's a flag or an alert or something that says, consider this in this patient. So there has to be things that will remind us to do it. Okay. We have to have the vaccines that are available and appropriate. Some of the challenges with some of the current COVID vaccines are the cold chain. Having a -70 freezer in my office would be great, but that's not going to happen. So we have to make sure that the vaccines that have developed have that in mind. I think they've done great things with the vaccinations and the vaccines that have been developed. 5 years ago would not have been possible, but we still have a lot further to go to make it more available. And so those are, I think, the three barriers: is changing culture, getting it so that it's in front of you when you do it, and then making sure it's easily accessible so you can deliver it.
Yeah, I think that, Vitaly's talked about pertussis. Maybe just spin back to pertussis for a second. I think that the barrier is that a lot of times we just don't know where that opportunity may lie. Now, I know you good folks at the American College of Emergency Physicians have put together a very nice website on this, which gives some touch points on where you can actually take some advantage. So, everyone wants to talk about whooping cough. It's a pertussis disease. It's in babies. It's very dramatic. You can hear it coming as the baby's coughing, whoop, coughing, whoop. But then we kind of treat the baby, whether it be admit, antibiotics, whatever it might be. But sometimes we just forget that, we better be, circling everyone in that family. This is an infectious disease. It's been in the house. This child's been coughing like crazy. What about the 3-year-old? What about maybe it's a 10-year-old or a 15-year-old? Or what about the mom or dad? What about the grandparents? And this is where the opportunity, the barriers there, because people just aren't thinking about that opportunity. So, really now we've kind of looked at this from a perspective of, if we do have someone who we suspect to have pertussis, and in fact a swab, nasopharyngeal swab for pertussis, we just go through the family, starting with the grandparents, saying, particularly if they happen to have some chronic obstructive pulmonary disease, something like that, they should be getting, when was the last time they got their a vaccine for pertussis? I've seen situations where the baby had whooping cough, the child was being treated for asthma because she'd been coughing for so long, and the mom has been treated for bronchitis. And actually, when we swabbed the daughter and the mother, they had pertussis as well. So I think that some of the barrier may be just not understanding where the opportunity is. And so just sort of educating around that. And once again, COVID, boy, that's got people thinking about vaccines. So this might be a great opportunity to find those great advantages that we can do with vaccine.
And as we move forward, when you put these together, these plans, one of the main things with emergency medicine is making sure you build a process that's efficient, to where it doesn't, because one of the things that I'm going to hear is, our job is to move people as quickly and efficiently as possible. So even adding a minute or 2 minutes or 5 minutes or whatever inevitably happens. Of course, it's never going to be as long as waiting for that urine sample. That never seems to happen in the emergency department. But it's to make sure that you have that process that says, I order this vaccine, it's readily available, comes down quickly, can be administered, even considering, secondary waiting sites, for that period that you're going to watch that patient afterwards, to ensure that there's no type of reaction, or just to keep an eye on them. And then keeping an eye on the vaccine records. And then something as simple as, making sure that we have it on our mind, and then we expand that patient population. You mentioned pertussis. Pertussis is a great example, because one of the best times for somebody to get the vaccine, the pertussis vaccine, is in a pregnant mother, because then she passes on that protection to her child that can't be protected. And of course, the newborn, the young child, is the highest risk for complications associated with pertussis, with their tiny little floppy airways. And so we have that opportunity to protect. And that's exactly what we did with my wife and I, is we both got our Tdap updated when she was pregnant with my second daughter. And so then we were protected. She was somewhat, protected as well. And that is something that we have a great opportunity. One of the common presentations we have in the emergency department is the pregnant female comes in with, whether it's urinary tract infection, whether it's a little bit of bleeding, whether it's just questions about intrauterine pregnancy, things like that. And that's a good opportunity, and just keep putting that into our minds, or a trigger. And I think the EMRs, as we move forward, are going to be something really important, to think about. So let's, as we wrap today, I want to get kind of your closing thoughts, take-home thoughts from both of you, as we start to crack this shell, this glass ceiling of vaccines don't belong in the emergency department, except for the ones that get us through ABIM General. To get us some take-home points that you think would be good at moving this conversation forward. Dr. Neame.
What John and I do in our lives needs to be integrated into the emergency room, which is, we do acute care medicine, but we do primary prevention of disease, public health medicine. And I think that just needs to be part of kind of the conversation that goes on. Once it's part of that, it's time spent, but it's time saved. I mean, it's all, for me anyway, in the emergency room I work in, it's all about flow. We just have constant flow of people. I'm sure it's the same in every emergency room in US and Canada. But if we can obstruct the flow somewhat, then we can spend a bit more time with the people that are very, very sick. We can also prevent people from coming in, to being really, really sick as well too. So for me, once again, as John and I do, we take care of both ends of the spectrum, and that's a conversation that needs to become part of the emergency department.
When you're sitting there at the bedside of a sick patient with COVID, having to talk to the family, and you're like, if this guy had gotten a vaccine, it could have prevented this disease. And it's kind of the yin and yang of medicine, if you will, is that when you've taken care of people so long in the acute, the serious, you start pulling back and saying, what can we do from a public health perspective? And it's in some ways it's more dramatic with COVID. It's a new disease. We've seen the impacts on a national basis. A lot of people have seen the impacts on a personal basis. So we know the importance of vaccinations. A little harder with diseases where it's we've done such a great job, we don't see it very often, or the impact is I get sick now and the bad outcome doesn't come till weeks or months later. And so we need to change the conversation. We need to change the mindset. We need to let people know that it's our job to take care of them when they come into the emergency department, but also to prevent them from having to come back if we can. So in the end, we want to help those who are acutely ill in front of us, but we also want to make sure that they stay as healthy as long as possible. So for me, it's just a part of who I am. I take care of the individual in front of me and try to make a difference on the population basis as well.
Talking with Dr. Dion Neame and Dr. John Hirshon, how can folks get in touch with you? What's a great way to either contact, questions, more information? Dr. Hirshon.
You can get me via Twitter, Dr. John Mark, at Dr. John Mark. You can also get me through my email address, which is jhirshon@acep.org. So JHIRSHON@acep.org.
And Dr. Neame?
Yeah, I hate to admit it, but I'm stuck to my phone. So best for me is my email, dion.neame@sanofi.com, and I will see your email. I'm a junkie. I'm a cell phone junkie.
So we got to time them out. See how fast you can send them, how fast you get a response. That's going to be your key. Challenge accepted. And there's actually, we got some some research here that will involve in the show notes as well, clinical decision support in the electronic medical record to increase rates of influenza vaccination pediatric emergency department. We'll make sure that link's available within the description. And as for me, you can contact me at rstanton@acep.org, rstanton@acep.org, at EverydayMed on Twitter. And we also have our ACEP Frontline Facebook page where we post pretty frequently. Every episode is going to be up there, as well as some extra stuff. And then make sure that you are subscribed to the podcast, listen, share, and make sure that you're getting every single episode. So we continue to put out great information. And I think this last year with a lot of the COVID-based and expansions from that have been some of the best content that we've had, just because we are evolving and moving with the advancement of the information, education, and evidence. So it's been an interesting year, to say the least, and I appreciate both of you guys coming on, as well as Susan and Vitaly as well being on here with us. Everybody at home can't see it because this is a audio version, but we've got a video with them on here as well, and appreciate everything. And as for me, thank you for tuning in. I'm Dr. Ryan Stanton, and this has been some ACEP Frontline.